Well, hello and welcome to the 27th Degree with Chris and Nancy. We'd like to welcome neurosurgeon Dr. Alvin Marcovici to our podcast today to discuss back pain and spine disease. Before we begin our conversation, I'd like to thank our sponsor, Baycoast Bank. Baycoast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review. And of course, 5-star reviews are always greatly appreciated. So anyway, to start, thank you so much for being here. We really appreciate it. I'm sure this is going to be a really informative podcast. Tell us a little bit about yourself and how you got into the field of neurosurgery. Why don't we start with that?
Well, first, I have to thank you for having me. I'm really excited to be sharing this with you and the 27th Degree. I got involved in neurosurgery in medical school. So I've lived my entire life along I-95 between Boston and New Jersey. I grew up in New Jersey, went to college in Waltham, went to med school in New Haven, went to training in the Bronx and in Manhattan and New York, so all along that 95 corridor. So I've gotten very used to being stuck in traffic. And as part of my neurosurgery journey, I was in medical school, and my mother was a pulmonologist. And she was a great inspiration to me as a human being and as a physician. And I always tried to emulate her. And in college and in medical school, I had done research in immunology. And so when I got to medical school, I wanted to focus on pulmonology, lung disease, as well as immunology. And I was going to be the world's greatest expert in a disease called sarcoid.
Sure.
And I'd even written papers in that. And as part of my med school rotations, they had a neuro rotation. And you had a choice of going to either pediatric neurology, neurology in the hospital, neurology in the office, and then there was neurosurgery. And it was a 4-week rotation. And I remember deciding which course to take, which program to rotate through. And I had heard the hours in neurosurgery were terrible. I said, when am I ever going to get a chance to see the brain again, right? So, 4 weeks of anything. So I signed up for that rotation, and then it was like an epiphany. I just was captivated by it. I'd seen the brain. I'd seen what neurosurgeons do. And instantly after that, I could imagine doing nothing else.
That's great. Isn't it great how in medical school we had the opportunity to try all these different things?
Oh, absolutely.
I mean, I think back to those times. It really was a wonderful time. I thought I was going to be a psychiatrist. I ended up as an internist. You thought you were going to be a pulmonologist and ended up as a neurosurgeon. But if we didn't have those opportunities, we would never really know what we would ultimately succeed at.
Absolutely.
And enjoy.
And a lot of the most rewarding rotations we had were in fields we may not have even entertained going into, but just the knowledge and seeing all the different aspects of medicine is very interesting.
Yeah, medical school was really, those were great times.
Indeed.
So,
Absolutely.
Dr. Marcovici, when you decide to do not only surgery but neurosurgery, how much more schooling do you need for that?
Well, so every physician goes through 4 years of college and 4 years of medical school, and then after that you go to residency, or what we call training. And in neurosurgery, there are 7 and 8 year programs. And once you finish that, you can actually go for additional training. So you talk about diversity in training. After I finished my neurosurgery residency, I actually went on to do an orthopedic spine fellowship.
Oh, really?
In Manhattan at Beth Israel in New York, not the Beth Israel in Boston. And that was, again, going back to what you were saying about medical school and seeing different aspects. I had seen the way neurosurgeons treat spine disease, and I was very interested in spine disease. And then the whole idea of orthopedists do this as well. That was very interesting and very valuable to see things that orthopedists treat and neurosurgeons tend not to treat as much.
I was always intrigued by that it's one of those fields that you have both orthopedists and neurosurgeons doing operations on the spine. I always wondered what the difference was in training and how they approached the patient.
Well, neurosurgeons see the spine as it's really an extension of the brain that's surrounded by bone, and orthopedists see it as a bone with nerves in it.
That's a great way to look at it.
So are the treatments a little bit different depending on if you go to an orthopedic or a neurosurgeon?
Yes, a little bit. Now, you have exceptional physicians who are both.
Sure.
And I learned a tremendous amount from the orthopedists. I would say that orthopedists tend to think of structure and stability and that more. And neurosurgeons tend to think about nerves and pressure on nerves and the spinal cord and things like that. So
now when you're talking back and spine disease, can we just kind of maybe get like a 101 on,
Sure.
What is spine disease and what is like the healthy back compared to a compromised?
Well, that's a discussion. I would need 3 more podcasts to
That's
explain all of
awesome.
that to you.
So this is part 1, everybody.
Yeah, indeed. So the truth is, all your listeners are probably very familiar with back pain, right? And we often mix the words back and spine, and they're sort of similar, but not 100%. In that, back pain is very, very common. Back pain is actually the second most common reason for lost days of work. Number 1 is the common cold. Number 2 is back pain. So it's a very common reason for visits to the emergency room. And pretty much, I'm sure your listeners over the age of 40 have had back pain at one time or another.
Right. So
Now,
true.
We think of the spine, and the spine is the bone that is in the center of the back, and the nerves are inside of it. But the back is really a complex organ of the bone, the nerves, and the muscles and the ligaments. And so when people eventually come to me as a surgeon and are discussing surgery, that often is and should be part of a long treatment process where people have examined all the other structures in the back, including the muscles and the ligaments and the function. And so we work very closely with physical therapists and neurologists and pain management specialists and chiropractors. And we work hand in glove to make sure that that's part of an integrated experience.
Do you find when patients go to you, they're already at like the I'm looking at surgery part, or do you see them way before that? And are you able to work with them before they get to that point?
I see patients across the spectrum. And I think sometimes when people come to me, they already have a fixed idea of what they want or what they need. And sometimes they get those ideas from their own research.
Yeah.
And other times, maybe someone has put that idea in their head. And it can be challenging sometimes to get people to think about their back differently. And it should be an education. The truth is, I, as a surgeon, focus mostly on the surgical treatment of back pain and spine disease. And sometimes people come to me first, but sometimes I also need to redirect them and say, it might be worthwhile to spend some time with a physical therapist. And I think today more than ever, people are searching for the quick fix.
Of course.
And one of the hardest things I have to do is to explain to patients that back pain and back problems is a chronic condition. And I liken it to things like high blood pressure or diabetes. No one has ever come to see you for diabetes and said, I want to be cured of this.
Right.
People have an understanding that when you go see your doctor for diabetes, that's going to be a long-term care and treatment. Similarly, people with back problems have to understand that it's usually a chronic condition and that it's not something where it's like going to the mechanic, swapping out the battery, and then all of a sudden you're fixed forever.
I
People
wish.
often have long-term issues with their back and need long-term care.
How does it all start usually? Because, if you're not talking like injury related or an acute episode. So I'm feeling I know you're not because you're so much younger, but I feel like creaky when I get up in the morning, right? And I'm like, oh, it takes like a while. Like, do you see like that normal progression when you say back pain is chronic? Like, what's actually happening?
So it's part of what we call degenerative joint disease. So
Okay.
we're born with all the cartilage we're ever going to have. And unfortunately, I hate to use the age word, but we get to certain age when we're a little bit more senior and we start wearing away that cartilage. And the discs in our back, these are the little cushions that separate the bones. They're the cartilage of our back. And so back problems and disc problems go hand in hand with other joint problems like shoulder problems, knee problems, hip problems. And if you think to most of the people that you know with back, hip, and knee problems, they're usually a little bit more senior, and it's that wearing away of cartilage. So the vast majority of people that I see haven't had an injury or a sudden event, or
Right.
it's just that long wear and tear of the cartilage and the bones on the joints.
Now, do some people get that wear and tear sooner than others? And like, why does that happen? Is there like preventative stuff we should be doing?
Well, there are some preventative things that we should be doing, but for the most part, it seems to be genetic or just someone's predisposition to something like that. So we certainly know that people have bad joints in families, and we know the family where everybody's gotten a knee replacement in their 40s or have had,
Sure.
my sister had a back operation, my mother had a back operation, my
Right.
aunt got a back operation. So we think that there's some genetic predisposition,
Right.
but there's some people who come to me with horrible backs in their 40s, and there are other people who come to me with mild degenerative disease in their 70s. And why that is, no one really knows.
And the level of pain that they have, I think, is probably pretty variable also, meaning someone can have mild disease and a lot of pain, perhaps, and someone with more severe disease may have less pain than you'd expect at times.
Absolutely.
Yeah.
One of the other challenges I face is that people often really, in today's data-driven world, want data and want that MRI.
Mm-hmm.
And I often have to tell them that I don't operate on MRIs, I operate on people. And if your MRI looks horrible, but you have no pain, there's
Right.
really no reason for
Right.
surgery. It's really taking care of people. One of the most challenging things about back problems and spine disease is that the MRI doesn't always correlate with the level of pain. So there are some people with mild looking degenerative disease and have horrible pain, and there are people with horrible looking backs and have horrible looking backs on MRI and have no back pain. And then
Why? Is that like part of like their pain tolerance, or part of it's just like they've compensated in some way? And
the honest truth is no one knows. There's a lot of research going on into this,
Yeah.
but no one really knows. And I think there's a tendency to say, oh, it doesn't look that bad, you're a baby. So you talked about pain tolerance, but
yeah,
most people tend to be pretty stoic and try to push through their pain. I notice more patients trying to suffer with their pain
Right.
rather than, babying it, if you will.
Right. And I think we've talked about this before too. Like people, when they start getting twingy, they're like, "Oh, it will go away. It will go away." And all of a sudden, it might be a year later, and they've just grown to that to tolerate it. And
Exactly.
it's not until they get progressively worse. Doctor, if you're looking at people with back issues, are you kind of grouping them like in, okay, this is kind of group one where they're just starting out with this and there's certain treatments for this group. Group two, it's like moderate. And then group three is that, heavy duty case.
Mhm.
Can you talk about if that's the way you group them? You might have a totally other way of
No,
grouping
you're
them.
exactly right.
But just kind of like, what are the common treatment paths and what are you looking for in each kind of case?
Well, I'd love to take your example, but go backwards. So let's
Okay.
take the severe ones. So most physicians know the red flags of back problems. So anybody with weakness or numbness, anybody who has loss of control of their urination or their bowel,
Right.
people who can't walk, or people who are just in extreme pain. Those are people who need to be often addressed surgically soonest.
Okay.
But in people without those red flags, then you have people who have chronic back pain, and often, as you mentioned, have been dealing with it for years.
Right.
Those people, some have reached out and have tried different treatments, and others have tried nothing. And so my job when I first see someone with not emergent spine disease is to connect them with the right people and say, surgery would be an absolutely last resort, assuming there are no red flags. And let's see if we can have you participate in physical therapy or chiropractic. And sometimes they need an MRI, and oftentimes they don't. A lot of times the challenge is when someone sees an MRI and sees all the problems, they want to jump into conclusions, or they feel that we should have some sort of level of certainty of, I see the problem here, I'm going to give you treatment X, and your pain's going to go away. And that's why it's sometimes can be frustrating for patients. They feel like they're bouncing back and forth. I got sent to this guy, I got sent to that guy, sent to the other guy. And the concern is that, maybe there's an impression that we don't know what we're doing. I think the truth is we don't know what really is the pain generator for back pain. And so a lot of our treatments are really trial and error. We send people for physical therapy, and that often helps most people. We work with our chiropractic colleagues and see if they can have an adjustment and see if that works. And many times it does. Most of the time, 80% of the time it works. But
Really?
A lot of times
That
it doesn't.
high?
Absolutely.
Huh.
Yeah, the vast majority of the most satisfying thing I tell patients is the vast majority of people with back pain will get better.
So that's like breaking news for me. So that's like 80, I mean, think about that. 80% of people can feel better in a couple of weeks.
Correct.
Like, who knew?
Correct.
So, but we're not talking about this like 84-year-old woman that's had like chronic back pain for 25 years or something who's like going on nothing, right?
We are talking about those people
Really?
too. So the amazing thing, so again, in this world where people want quick fixes, people show up and say, I want to be fixed. I've
Yeah.
had this pain for 5 weeks and, you need
Done.
to fix me. I hear that every day. You need to fix me. And it's sometimes gratifying for me to tell them, let's give you some medications, have you see one of my chiropractic colleagues, and I'm telling you, in 6 weeks, you're going to be better. And they're delighted that they come back 6 weeks later, their pain is better, and they didn't need surgery. Now, here's the bad news. The bad news is a lot of those people with back pain, even though they're better, there's a good chance that their pain will recur.
Right.
Yeah.
Right. So when you send them to a physical therapist, just in broad strokes, the physical therapist is strengthening supporting structure.
Exactly right. So if you remember, I had mentioned that the back is not just the bone and the nerves, but our backs are surrounded by muscle and ligaments. And if we work on strengthening those muscles, improving the flexibility of the ligaments, and for people who've had back pain and gone to physical therapy, they know that the physical therapist has told them to work on the core, not just abdominals, but the obliques and the back muscles itself. And by strengthening those, you can actually help support the spine and the discs, and the spine can actually heal itself. And a lot of people get better with that treatment.
And with chiropractic, like some people are afraid of chiropractors because it's like, like they hear that noise and they're like, oh, but you've seen great results. And I know we've had your friend on the show who's chiropractic, and he was great,
I think one of the big tragedies of medicine is traditionally trained physicians like myself and Dr. Jonkas don't collaborate more often with the less traditional fields of acupuncture and chiropractic. And I think the people who lose from that are the patients. I work very closely with a number of my chiropractic colleagues, and they do great work. The popping is sort of a side effect of what they do. What they're really doing is opening up the space in the joints.
Okay.
And by opening up the joints, they also open up the space for the nerves and allow for that healing to occur,
Right.
because that nerve is
Reduce the
chronically
compression.
being compressed, and for a little bit of time, it gets relieved and allows blood and nutrients and other things to flow into that area and allow for healing. Now, when they're doing that, there's often that audible pop, but the goal is not the pop per se.
Right.
So now when people are doing all that good stuff, like let's do a little bit of some myth busting.
Mhm.
What is stuff like they shouldn't be doing? Like I'm going to give you some examples. Like, okay, I'm going to sleep on the hardwood floor tonight.
Mhm. So the hardwood floor is not really going to make a difference, and I hope you don't have any mattress sponsors, but
No. We don't.
mattress
No, we don't.
the mattress companies are making a fortune by telling people their back problems are coming from their mattress, and people go out and get, mattress prices have
Yeah, crazy.
become exorbitant, and
Right.
people are desperate,
Yeah.
and so they're willing to pay anything. Unfortunately, you should have a decent mattress. So if your mattress is 20 years old, it might be time to change it. But pillow top, memory foam, coil mattress is not going to really change. You should have a comfortable mattress.
So what about I'm going to use moist hot heat or versus the frozen bag of peas?
So my number one question that I get from patients is, what's better, heat or cold? And everybody is different. Some people do better with cold. Other people do better with heat. So cold has an advantage because it's sort of like an anti-inflammatory. So some people feel better with that. Warm is nice because it often acts as a muscle relaxant. And so many people do well with that. I actually tell people to try either. And I even have some patients who do both. They come home after a rough day and they apply ice. And then later in the day, they apply heat. So it's really one of those trial and error things.
Right.
There are some things that we can do to help our backs. So one thing that people are surprised about is if your primary care doctor has told you to quit smoking, well, your neurosurgeon is going to tell you to quit smoking as well.
All right. You have to explain this one.
Well,
Yeah,
so
that makes sense.
the mechanism is not
I'm sure it will to me in a minute.
the mechanism is not well understood, but people who smoke have more back problems and tend to have more degenerative disease. What we think is the cause is the disc itself has no blood supply. So the entire, all the nutrients and oxygen that flow into the disc flow from the surrounding tissues. And you can imagine that's already a tenuous sort of thing.
Exactly.
So anything that impairs that further,
Yeah.
like smoking, makes that worse. And if you do develop back problems and you smoke, you're actually going to do less well if you do get treatment. So if you get physical therapy or pain management or even surgery, people who smoke, and this is nicotine, do less well. And unfortunately, we know the offending agents is the nicotine. So in terms of back problems, the patch and the gum are just as bad for you as smoking cigarettes.
No way.
But it's really helpful when someone is going for surgery, whatever it may be. It's like my opportunity as a primary care doctor to get them to quit smoking, because the
absolutely.
outcome will definitely be better if they're not smoking. And I tell them that. And a lot of surgeons nowadays don't even want to operate on,
Absolutely.
do elective surgeries, at least on patients who smoke.
And sometimes patients may even fib about quitting smoking.
Yeah.
Come on.
Yeah, well, because they're in a lot of pain and they want the treatment.
Yeah.
And so we'll do like some nicotine tests just to double check. But I agree with you 100%. There are a lot of patients that you've seen a dozen times and you've told them to quit smoking. But then when I tell them, if you really want to do yourself a favor and you want to have a good outcome after the surgery, you can quit smoking. And sometimes that's the final straw that actually gets them to do it.
So if we have a bad gene pool, like you made me scared earlier because I'm like, oh man, my future isn't bright. So what are some of the things I can do now to kind of, I guess, obviously not smoking, to like really preserve what I have?
Well, aside from that, we know that maintaining a healthy lifestyle. So regular fitness is very important. So we were talking about physical therapy and keeping that core strong. Well, that's just really jump-starting that lifetime habit of being fit. And you'd be surprised, just going for a run or for a walk can do a lot for strengthening your core, because
it makes a big difference.
it makes a huge difference. Your core connects your top to your bottom, and even when you walk, you're using that core. And while you're doing that, that's helping support your spine. So unfortunately, some people remember the old days. So when people had back problems, the old school doctors would say, "Oh no, bed rest for 2 weeks. Don't only get out of bed to go to the bathroom. Even take your meals in bed." And thankfully, people didn't listen to their doctors, and we found out that those people actually did better. So people who remain active, even though it hurts, actually do better than people who are sedentary.
Makes sense.
What happens if someone went to lift up something really heavy and had the acute injury? We've talked a little bit about like the chronic stuff, but you also see acute injuries as well. And so is the treatment a little bit different, or are you still recommending like PT in general, I guess, because I know it's case by case?
It's case by case, and it's hard to generalize, but we see a lot of people with acute injuries, and we talk about back problems and we talk about spine problems, but the underlying cause can be very, very different. So some people have a strain, muscle. They either pulled a muscle in their back, or they pulled a ligament in their back, and they just need to get over that. Other people have what we call a herniated disc, a disc in their spine that's out of place, and that treatment would be slightly different. And then some people have severe arthritis in their back, and what's happened is that pulling, that sudden event, pushed them over the edge, and the treatment for that is even slightly different. So it's hard to generalize just by the symptoms as to what you need. But the thought process from our standpoint is sort of the same, in that you want to try the least risky and least invasive treatments first. You want to make sure you come to medical attention. Don't ignore it, because remember those red flags. So if there are any of those red flags, waiting is not always good, because you can end up with permanent injury. And then if there are no red flags, going through that process of first giving it some time, then getting some treatment. And if it doesn't help, then moving on to the next step in the pathway.
I like the fact that you had mentioned that, excuse me, that MRIs aren't really, you don't treat an MRI, you treat a person. Because I get this all the time in my office. Someone will come in with back pain, and they have a really fairly unrevealing exam, but they want the MRI to know what's going on in there. And I try to dissuade them from it. And sometimes I'm successful and sometimes I'm not. But, a lot of times, if you do an MRI, you find patients who have, really horrible looking backs by MRI, but they get better anyway, as you mentioned. And then you have those patients who really don't have a lot of findings, who sometimes just don't get better, which is interesting also.
It is. And sometimes when you do the MRI, you open up a can of worms.
Right.
Because the MRI looks horrible, but someone just pulled out their back and all they need is, some rest and, maybe some ibuprofen.
Right.
But now you have this MRI that's sitting there. Right. And there's a very common adage that we use in medicine: never order a test if you're not going to do something with the information.
Right.
So if you've set upon a course of action, if together, and it's always a joint decision between the patient and the doctor, and said, if we're going to do 6 weeks of physical therapy and try some ibuprofen, the MRI is not going to change that. So maybe that's early. If it's going to change what we do, then it might be worth getting that MRI sooner. But otherwise, never get a test if it's not going to change what you do.
Yeah. I mean, I have a personal story that is interesting. I know we're talking about more lower back issues, but Nancy knows this story. But I had a neck issue where one day I developed this terrific neck pain, and I had, radiating pain down my arm, and I actually had some hand weakness too. I was having a difficult time like holding up charts and things of that nature. So I ended up getting an MRI, which was probably a mistake at the time, but I did because of the hand weakness mostly.
Of course.
And, the radiologist called me up and he said, "Oh God, this is terrible. You have to have surgery immediately. It's really, you have this horrible disc. It's herniated and this and that." And I went to a friend of mine who was a chiropractor, and he said, well, let's try some other things first, because I didn't want to have surgery, of course.
Of course.
And because then I wouldn't be able to work. And I got to work. I can't do that.
Doctors hate having surgery. So.
Right. So I went to the chiropractor, and he did a number of things. Some were physical therapy techniques, et cetera. And I took some anti-inflammatories, and I think I took a course of steroids at one point too. And it actually got better over 6 weeks. And every once in a while I have a little twinge, but it never really came back, fortunately. So I was happy I didn't go the surgery route based on the MRI findings. I went more based on how I was feeling, and it did improve.
But that episode that you relate makes perfect sense, and I don't say it. I don't think it deviated anything, even though you didn't have surgery. What the MRI did, so you had one of those red flags. You had weakness in your hand,
right?
Which means we should get the MRI early, because if there's, God forbid, something horrible on there, you want to intervene,
right?
And you decided not to intervene, but which wasn't a mistake. You got better, but in those sorts of instances, you want to be very vigilant. So you wouldn't say, oh, okay, I'll see you in 3 months.
Right.
You'll say, well, I'll see you in a couple of weeks, and if your hand is not better or if it's getting worse. So the MRI was very helpful in that instance.
It was.
And that's why you have to treat each individual case. We're talking about generalities here, but each individual case has to be treated for that unique individual.
Absolutely.
PrimaCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
Can we talk more about the surgical side of things? So what types of things are you doing surgery for? Like, can you talk about like starting someone out with the physical therapy, maybe that didn't work, and now you might be at the point where you're really considering surgery. Can you kind of walk us through that a little bit and then talk about the surgery itself?
So aside from physical therapy, I do work with a lot of other doctors, like chiropractors. I also have pain management colleagues who often will inject steroids. Sometimes when someone comes to your attention with back pain, we'll often give people steroids because they're very powerful anti-inflammatories. The problem with steroids is they have a lot of side effects. They can give you diabetes, they can give you ulcers. And the advantage of injecting them is they're much more effective because they're injected right at the spot of the problem. And you tend to have fewer of those other side effects. If all those treatments fail and there are no red flags, they often come to surgery. And this is where the surgeon has to really look at the patient and the MRI and see what's wrong. And there are several possibilities. So one possibility, which is most common, is what's called the herniated disc.
Yes.
This is very, very common. And these cases are often very gratifying because they are very, it doesn't take a long time to treat them, and patients are usually very satisfied. And
what is a herniated disc?
So if you imagine the discs being the shock absorbers in between each of the bones in our back, and those bones are called vertebrae. In between each vertebrae is a disc. The disc can wear out, and then a piece really breaks off. The disc is often referred to as a jelly donut. And the firm outside breaks down, and the sort of squishy jelly inside pushes out. And if it pinches a nerve, it can cause horrific pain. Right? So if that needs to be treated with surgery, we have a very straightforward operation where we make a 1/2 inch or even smaller cut in the back. We go down to the spine, and to look inside, we have to remove a little bit of the bone, just a tiny little bit, a couple of millimeters. We look inside with either an endoscope or a microscope, find that little piece of jelly donut that's out of place, and we just pluck it out. And we don't take the whole disc out, just the part that's out of place and pushing on the nerve. That operation takes about between a half hour and an hour.
Really? That's it.
patient, that's it. And the patient spends another couple hours in the recovery room, and then they go home. And usually they're very, very pleased and have, if not immediate, very quick relief of their pain.
So I would imagine you've had a few patients
Yes.
have this. Did one of those patients just like stick in your mind? And can you talk anonymously about them a little bit?
I've had so many patients. I mean, these are some of the most gratifying patients, the ones that have a disc that's been tormenting them
Oh my
for
God, yes.
months. And then, you do this half-hour procedure and they think you're...
boom.
Exactly. And
Oh my gosh.
these are the patients who come into the office and give you a hug and say you gave them your life, you
Of
gave them their
course.
life back. But the truth is, for a neurosurgeon or a orthopedic spine surgeon, it's a pretty straightforward procedure,
Oh, that's
and it can be very gratifying. Now, there are other conditions in the spine, things called stenosis or malalignments of the spine, spinal alisthesis, which are a little bit more involved to treat.
When you treat something surgically, is that it? Or do you expect them to come back for surgery in like 5 or 10 years?
There's always that risk. So we always want to do a surgery that is definitive.
Okay.
If surgery is going to be a last resort, it should be your last resort, not the last resort 3 or 4 times over. Unfortunately, sometimes the surgery, people with bad backs have long-term problems.
Right.
And whatever happened at one disc in their back is now cascades. And so people end up with multiple surgeries.
Right.
And we have plenty of patients who come back.
Now, I'm sorry. Go ahead.
You're hogging all the time.
I know it's a bad flaw that I have. I'm sorry.
You mentioned spinal stenosis. That's always a frustrating problem for my patients.
Spinal stenosis can be very frustrating.
Because tell me if I'm wrong, but I don't think there's a really easy surgical fix for that, is there?
Can we define spinal stenosis
Well,
sure.
too?
You can think of spinal stenosis as like a napkin ring.
Okay.
So the nerves in the spine travel through this big canal. And the canal has a certain diameter, but at certain points, as a result of a buildup of arthritis, the nerves can get pinched. And we call that stenosis. And you can think of it as a napkin ring around a napkin. Sometimes stenosis can be easy to treat surgically, depending on where it is.
Okay.
And other times it can be difficult to treat if it's in a what we call more lateral location. Then it may need a more involved procedure. Sometimes we can just do almost the same operation as we do for a disc
That's good.
or stenosis, and those people are equally grateful.
So those are the patients who have like a single level of spinal stenosis, not
single
multi-level disease. That becomes a little more complicated, I'm guessing.
Correct. So a single level or even multi-level of what we call central stenosis.
Okay.
And then there's something called neuroforaminal stenosis.
Yes.
And that can be very difficult to treat because it often covers many areas of the spine, many levels, if you will. And trying to decide which level you want to treat is one challenge for spine surgeons. And the other thing is, if you have many levels, the treatment is quite invasive. And that's when you talk about things like spinal fusions and the like.
Right. If you go to the supermarket, you see all the older
What?
folks.
We're all talking about
No,
food, like
serious,
napkin
no,
rings
serious.
and jelly donuts,
Leaning-
and now we're at the
They're
supermarket.
all leaning over their carts, and
Yeah.
they're
Yeah,
walking
yeah.
like this. They probably have spinal stenosis.
No. Oh, they're
Because
creaky. That's kind of me in the morning.
When they lean forward, it relieves some of the pain.
Yeah, it
Yeah,
opens up
they
the
rule it.
space. So you
Right.
think about that napkin ring, it actually opens up as people bend forward. And we always ask that question, do you ever feel better when leaning on a shopping cart? And if they say yes, that's pretty...
See, I know what I'm talking about
I
here.
never doubted it. Not once. Not once. So with stenosis, and you use those big fancy words, is that some of your more complex surgeries that you do? Like, what's the most complex surgery that you do?
Well, the most complex cases are like spinal reconstructions, where someone has destruction of several bones.
I am so grateful that there's people like you in this world.
It's very rewarding. You talk about cases that stand out in in your mind.
Yeah.
It's some of those cases which
Okay.
really stand out in your mind, where someone has such a severe, complex problem, and it takes a lot of work and a lot of effort, but eventually you can get them to a good place.
These are patients who had mechanical injuries of some sort,
Either
or
mechanical
accidents?
injury. I'll if I could share one anecdote
Sure.
with you. There's a gentleman here in Fall River who unfortunately had a lot of social problems, and we know that drug use is a problem here in the Fall River community. And unfortunately, he ended up losing contact with his family, got involved with the wrong crowd, and basically the crowd he was hanging out with was his drug use crowd. And when you inject substances in your blood, the technique is not always sterile, and bacteria get into your bloodstream. And one of the favorite places for bacteria to land is in the discs.
Oh.
If you remember that I said that the discs have no blood supply,
Yeah.
well, bacteria love that because there's no
Oh.
immune cells to fight it. So
Right.
they land in the disc and they eat up the disc. Eventually they can eat up the disc and start eating up the bone, and literally the
God.
spine can start falling apart. And this poor gentleman, he had several of the bones in his back just completely eaten away. It's like he had no spine. And then all that pus that was forming was pressing on a spinal cord and putting him at risk for going paralyzed.
Oh my God.
Mm.
And so that was an emergency, and we had to go in there and treat him. And it was a very long operation, very involved for him. And I told him, you might go paralyzed as a result of this operation, or we could end up with complications and you may not even make it.
So then that's tricky technically, but it's also tricky because the baseline of the patient is compromised from drug use.
Yeah, absolutely. Absolutely. And he was very frightened, and he was a young man.
Of course.
And we went in there, and luckily everything went well. We replaced his infected bone with healthy, good bone, got him to fuse and put screws and rods in his spine to hold everything together because all the bone had been eaten away.
Mm.
And then every time I saw him afterwards, I reminded him how close he was to not making it.
Right.
And he really took that to heart. He realized that he came about as close as you can come to going paralyzed or not
Right.
surviving. And he broke off all his contact with his
Oh my God.
his usual, shady crowd. He reconnected with his family. He now works 2 jobs.
Oh
He
geez.
is actually his boss had even called me and told me what a great worker he is now and how motivated he is to do the right thing.
Oh my God.
And he's doing great. And this past Christmas was the first Christmas in about 10, 15 years that he had with his mom. He's reconnected with her, and he's really developing a social network of really honest and decent people that are going to keep him on the right track. And I'm just thrilled that I could be part of that.
Oh my God. That
That's a
would
great
be
story.
so rewarding.
Yeah, right here in Fall River. So it's one of the privileges we have as physicians that we can make such a profound impact
Sure.
in someone's life. It's really a privilege.
That's great.
So, when patients are at the point where they know they need surgery, and that has to be overwhelming to some patients. So, how do you know where to go? How do you even fathom what type of surgery you need? All that.
This can be very, very tricky for patients. I think a good rule is if you see a doctor and you don't have any of those red flags, and your doctor should explain to you if you do have any red flags or not and the reason behind that. But if you don't, if the first thing they mention is surgery, you may want to seek a second opinion. Doctors and surgeons are human beings like anybody else. And, often if your only tool is a hammer, every problem becomes a nail. So
It's a great saying.
it's true. And surgeons sometimes just see everything as something that needs to be fixed mechanically, with operation. We know, and now there are studies that are coming out, that if you go to what we call a integrated practice, a practice, as I mentioned, where you have pain management, physical therapy, neurology, all involved together, those patients tend to do better than if you go to a sort of solo practitioner, because they may just be in that sort of hammer mentality. And I always think that it's the surgeon's obligation to try to find the smallest surgery that you need. It's often surgeons try to sometimes fix everything. I see a little bit of this, I see a little bit of this, but people are not cars. It's not, rotate the tires, change the oil, replace the battery. It's human beings, and the more you do, the more risk the patient takes on. So you want to try to find the smallest operation to benefit the patient for their case. That being said, sometimes the smallest operation you can find is a big operation, but your surgeon should be trying to do that for you. And then you need to find someone that you just have faith in, and someone you can put your trust in, and it's making that connection. And there's nothing wrong with seeking a second opinion. I often encourage my patients who are on the fence, because surgery is a scary thing.
Of course.
And they say, well, I don't know, should I have surgery or not? Say, go to a second opinion. Let me refer someone.
Can most of these surgeries, like when at the point where you're doing surgery, it's covered by insurance and not considered like elective if they're in that much pain? And
the vast majority of spine surgeries are covered by insurance. So it depends on the plan, but usually that's not something that patients have to worry about.
Nice.
It's covered. Luckily, the inpatient and the hospital stay is covered by insurance. And of course, we all have those co-pays and deductibles that we all struggle with, and patients do. But
I'm going to ask a doctor question, like just guidelines, I guess. So you said that sometimes there's a little overlap between orthopedics and neurosurgery. So for a PCP, are there rules of thumb, like who they refer to with back pain?
So you said there's a little overlap. I would like to say that there's a lot of overlap.
Okay.
So I think if you have a decent spine surgeon, whether it's an orthopedist or a neurosurgeon, they may have a little different philosophy or perspective.
Okay.
But they're excellent orthopedic spine surgeons, and
So you're not going to go wrong either way.
You're not going to go wrong.
Okay.
I think just like with patients, it's that contact, and your PCP is your advocate. That's the person who's fighting for your behalf, and hopefully your primary care physician is going to send you to someone that they trust. Right. The biggest question that I encourage and people ask me is, if you had to have surgery, who would you go to?
Oh, yeah.
Unfortunately, I hate to say it, but nowadays, a lot of health systems are being stuck with these networks, and you're stuck to a network because of your insurance.
Right.
And it limits the choice. So that is a little bit unfortunate. But that being said, most networks have a exceptional or excellent spine surgeon in that network.
Nice.
And even if you're forced to stick within the network, you can find it's
somebody.
And it's usually not a secret. People know who the good surgeons
That's
are.
so true.
I'm looking for someone who is thoughtful and is not going to do surgery on everyone. So, a red flag for me as a primary care doc is if I'm referring to a neurosurgeon and they want to do an operation on every single patient, that's probably not someone long-term that I want to continue to refer to, because like you mentioned, a lot of these patients ultimately don't require surgery. So, you want someone who's thoughtful, who's going to have the patient's best interest at heart, and think, well, maybe we try physical therapy first, or we try this. And then there are times you just need to do surgery because they have those red flags, as you say.
Of course.
But I think that's important to me as a primary care doctor. And then, you get a sense of where the outcomes are over time, too.
Right.
You know who does, who has better outcomes with their patients and that. So you get a sense of that.
So one of my last questions is, we've seen such great advances in technology. Can you talk a little bit about what you've seen that you were like, oh yeah, like that's happened over like the last 5 or 10 years and what you're seeing coming down the pike?
So the advances in technologies are phenomenal, and it seems like the advances are accelerating. So when I learned how to do spine surgery, we just sort of free-handed it. You learned what looks right and did that.
Yes.
And then came navigation. So it's basically like GPS for your car. So you could use a little pointer or a little, a little cursor, and it'll tell you where to go and how to find it. And that increased safety and precision. And now, most recently, we have robots. And people often ask, like, is the robot going to do the surgery? And the truth is, no, the robot doesn't. But it makes you, it sort of forces you to do what you want to do. So if you look at an MRI and you say to yourself, this is what I want to do, this is the procedure I want to do, this is where I want to place screws, the robot will help you do that, so that if you look away or if your hand is not at the exactly perfect place, the robot will make sure you're in that perfect alignment 100% of the time. So it's just phenomenal. The hospital I work at here in Fall River actually has that robot, and it's actually one of the busiest robots in the country.
Wow.
Yeah, this hospital's already done 700 cases using the robot. In addition, there's also now an endoscopic spine surgery where it's done through a tiny
Really?
little, So people are often familiar with endoscopy for
Yeah.
hernias or for gallbladders, and that technology has been around for a long time. Endoscopy for the spine is relatively recent and is now just sort of being the ways you can use it is increasing exponentially. So it's phenomenal, and I'm very curious to see what's going to happen in the next 5-10 years.
I know years ago there was, and maybe this is still going on, but there was all this excitement about disc replacement surgery. I think they were doing some work at Yale on that and whatnot, but I don't hear much about that anymore.
So disc replacement surgery is around. It still has a very big footprint and a very big role. I was actually lucky enough to be one of the first doctors in Massachusetts to use disc replacement, and I did that about 20 years ago.
Wow.
There are, like all new technologies, it's not perfect for everyone. And there were a lot of issues of, if the disc replacement worked, it worked great. The biggest challenge was, if it didn't work, there were very limited ways of trying to address it and fix it.
Okay.
And so disc replacement in the low back, excuse me, disc replacement in the low back is not as popular as it once was. And there's still a lot of research on that. And I'm convinced it's going to come back and resurface. What has become very common is disc replacement in the neck.
Okay.
So I had mentioned spinal fusion, where you take out a disc and fuse two bones together. That puts additional stress on the spine. And the concern is, you talk about repeated operations. If you fuse two bones in the neck, is over the course of time, the next disc going to go, and the next disc, and the next disc. So what if you could just replace the disc? And so disc replacement in the neck is very popular. It's often used. If used in the right patient, patients do very well. They do fabulously, and hopefully they won't need additional surgery down the line. Remember, in spine surgery, 10 years is not a long time, so
Right.
we may have to wait even longer. But the early data, and by early I mean 10 years, seems to be very promising. And disc replacement has a huge role in spine surgery.
That's great to know, because I have, some patients who've had multiple fusions of their cervical spine, and they can't really drive. They can't, turn their head, and it's really affects their quality of life.
Yeah, it's very
quite a bit.
debilitating.
It's very debilitating.
And so preventing that by now using a disc replacement. Now, the biggest concern about disc replacement is anything that's ever been put into a human body always wears out, right? So we
Right.
know artificial knees, artificial hips, they all wear out. The spine doesn't move as much as a knee or a hip,
Hmm.
so hopefully it'll last a lot longer, but we don't know.
Dr. Marcovici, Dr. Marcovici, once you have that fusion done, is there ever going back from that and saying, okay, undo the fusion and I want to do this disc replacement?
No, unfortunately, once your spine is fused, it's fused forever.
Okay.
So there's no way to then restore motion at that level.
Right.
And that's why you have to think about it before you jump into that sort of surgery.
We'll have to have you back to talk about neck issues at some point.
Sure. I would
That's a
love that.
whole other topic. You could probably do a whole podcast on, I'm sure.
I wanted to
Yeah.
say something important though.
Go ahead. Yeah.
So Dr. Marcovici had made a really good point where you're saying that the robot down in Fall River is the most busiest in the country.
One of
So there's not a lot of reason sometimes to go outside of this local area and always go to Boston for things.
So part of my role here and part of it, I've been in the Fall River area for 21 years. And in that time, I've worked with Dr. Jonkus and others to try to offer the people of Fall River and the greater southeastern Massachusetts exceptional care so that they don't have to travel.
Nice.
And the skill set of the people and my colleagues now is exceptional. And I think for 99% of conditions, the care you can get here in Fall River is exceptional, equal
Absolutely.
to anything you get in
That's
Boston.
Right, I agree. It's less and less common that people leave the area for procedures now, surgeries or whatnot.
And I don't think you need to.
No, I agree.
We were talking before we started recording about how important it is to keep people in their support network.
Mm-hmm.
And if you pull people out of their support network, they tend not to do as well. And this is not just true for spine surgery, but it's true for a whole host of conditions.
Absolutely.
And so keeping people close to their friends and family is important and helps with that rehab process.
Nice.
I think we're drawing to a close here.
I guess, because
It's-
I know we always this hour flew by and it's like
It always does.
we
It
want to
always
hold
does.
you hostage for another hour, but
Well,
we'll
that's
let you
just
go.
because the conversation was so good.
And we just scratched the surface probably on some of this stuff. We could have
Absolutely.
gone on and on, but
Yeah.
we'll definitely have you back at some point to talk about neck disease and to talk about maybe we can do one on the brain also.
That would be
Sure,
awesome.
I would be delighted.
That'd be fascinating, I think, for
course.
our viewers. So thank you so much for participating and sharing your knowledge with us. This was really great, and I'm sure that everyone watching will really get a lot out of this. How do people contact you?
So I can be reached. There's one number. I'm affiliated with Hawthorne Medical Associates, part of the Steward Network,
Mm-hmm.
and we have one contact number, and you can reach me and my colleagues through 508-996-3991.
Great.
And we're also, you can also find us on the internet and on Facebook and on Twitter and Instagram.
That's
Nice.
awesome. And is there one last message you want to leave the audience out here in regards to?
For all
Back
those
disease.
people with back pain, there's no reason to suffer.
Mm-hmm.
So if you're suffering home alone, if you're lying on the floor right now with an ice pack and taking Motrin, call our number 508-996-3991. Myself or one of my colleagues will take care of you. There really is no reason to suffer.
Nice.
That's a great message.
That's a
Thank
great
you.
message.
Thank you. So I want to thank all of you for listening to our show. If you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to Ron Gamache for our intro music and to BioSkills of Northeast for producing our show. Bay Coast Bank, also our sponsor, who's just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And of course, thank you, Dr. Marcovici. We greatly, greatly appreciate you being on the show and sharing your knowledge with us.
I was delighted to be here. Thank you for inviting me.